Hello everyone. In today's session, we will explore substance-related and addictive disorders. We will divide today's lecture on substance-related and addictive disorders into three main parts. First, under the topic, what are substance-related and addictive disorders, we will define what this category means and examine how it is classified and conceptualized in the DSM-5. Second, we will focus on alcohol-related disorders as a representative example of substance use disorders and discuss its clinical features and associated risk factors. Finally, we will look at gambling disorder to understand the nature of behavioral addiction, an addiction not involving substances, and reflect on how the essence of addiction extends beyond the use of chemical alone. First, let's begin by clarifying what we mean by substance-related and addictive disorders. The term substance refers to any drug or chemical that affects the brain and behavior. For example, alcohol, caffeine, cannabis, and hallucinogen all fall under this category. In the previous DSM-4, two separate diagnoses were used: substance abuse and substance dependence. However, in the DSM-5, these have been integrated into a single continuous concept known as substance use disorder. In other words, rather than distinguishing between abuse and dependence, DSM-5 views substance use problem along a continuum of severity ranging from mild to severe level of impairment. There are also two other important terms related to substance use. Substance intoxication refers to the acute physiological or psychological state that occurs immediately after substance use. Substance withdrawal describes the physical and psychological symptoms that emerge when substance use is reduced or discontinued. As illustrated in the DSM-5 framework, the entire category is referred to as substance use-related and addictive disorders, which is further divided into substance-related disorders and non-substance-related disorders. Substance-related disorders include substance use disorder and substance-induced disorder, while the primary example of a non-substance-related disorder is gambling disorder. This classification highlights an important insight. Even behavior like gambling, which do not involve ingesting a substance, can activate the same neural reward pathway as drug use. Now, let's examine the diagnostic criteria for substance use disorder. According to the DSM-5, a diagnosis can be made when two or more criteria are met within a 12-month period. These criteria are grouped into four main domains: The first domain involves impaired control over substance use. This includes using substance in large amount or over a longer period than intended, repeated unsuccessful attempt to cut down, spending excessive time obtaining or using the substance, and experiencing cravings or a strong desire to use. The second domain is social impairment. Substance use may cause failure to fulfill major role obligations at work, school, or home. It can also lead to interpersonal conflict and a reduction in important social or recreational activities. The third domain is risky use. This refers to using substances in physically hazardous situations, for example, driving or operating machinery while intoxicated, or continuing use despite knowing it is causing or worsen health problems. The final domain involves pharmacological criteria, which include tolerance and withdrawal. Tolerance means that increasing amount of the substance are required to achieve the desired effect, while withdrawal refers to the physical and physiological symptoms that appear when use is reduced or stopped. The DSM-5 also classifies the severity of the disorder based on the number of symptoms. Mild, 2 to 3 symptoms. Moderate, 4 to 5 symptoms. Severe, 6 or more symptoms. In summary, substance use disorder is not simply a matter of bad habit. It is a complex condition involving a breakdown in self-control, impairment in social functioning, and physiological dependence. What we see here represent the main categories of substance use disorders as outlined in the DSM-5. The DSM-5 identified 10 primary classes of substances plus one additional category for other or unknown substances, making a total of 11 categories. Some familiar examples include alcohol and caffeine. Although these substances are commonly used in daily life, when used repeatedly and without control, they can produce dependence and withdrawal symptoms, operating through the same neurobiological mechanisms as other drugs. Other major substance classes include cannabis, hallucinogen, inhalant, opioid, sedative, hypnotics, anxiolytics. Stimulants include substances like cocaine or amphetamines, while tobacco is recognized as its own distinction due to its strong addictive potential. Finally, there is the category of other or unknown substances, which covers new synthetic drugs or chemicals that cannot be clearly classified within existing groups. In short, the DSM-5 organizes this into 10 primary substance classes plus other substances. The key principle is that any substance that stimulates the brain neural system, leading to impaired control, dependence, and withdrawal, can be classified under substance-related disorders. Now, let's turn our attention to alcohol-related disorders. The most representative and clinically prevalent form of substance use disorders. Among all addictive conditions, alcohol-related problems are the ones we most frequently encounter in clinical practice. Let's take a closer look at the specific components of alcohol-related disorders. According to DSM-5, alcohol-related problems are categorized into three main conditions. First, alcohol use disorder. This refers to a pattern of problematic alcohol consumption leading to loss of control, social impairment, and physiological changes such as tolerance and withdrawal. In short, it involves repeated use of alcohol despite clear negative consequences. Second, alcohol intoxication. This describes the acute state following recent alcohol consumptions, what we typically call being drunk. It includes immediate behavior and psychological changes such as slurred speech, impaired coordination, and reduced judgment. Third, alcohol withdrawal. This occurs when a person who has been drinking heavily for a long time suddenly reduced or stopped consumption. Withdrawal symptoms may include anxiety, tremors, or sleep disturbances. Let's now look at the core features of alcohol use disorder, which are the four key domains evaluated during diagnosis. First, impaired control. This includes drinking larger amount or over a longer period than originally intended, and repeated unsuccessful attempt to cut down or control drinking. It also involves spending a great deal of time in activities related to alcohol use or experiencing strong cravings or urges to drinking. The second is social impairment. This refers to failing to fulfill major responsibility at work, school, or home due to drinking. It may also involve interpersonal conflict and a reduction in social, occupational, or recreational activities. In short, it's when alcohol use begins to disrupt relationships and daily functioning. The third domain is risky use. This includes drinking in physically dangerous situations, such as before driving or in hazardous environments, and continue to drink despite knowing it causes health problems. In other words, the person continued to drink despite clear awareness of the risks. Finally, there are pharmacological criteria which involve tolerance and withdrawal. Tolerance means needing more alcohol to achieve the same effect, and withdrawal refers to symptoms such as anxiety, tremors, and insomnia when drinking is reduced or stopped. Next, let's look at alcohol intoxication. Alcohol intoxication refers to a clinically significant behavior or psychological change that occurs shortly after recent alcohol consumption. Examples include aggressive behavior, inappropriate social interactions, emotional instability, impaired judgment, and difficulties in social or occupational functioning. In other words, this goes beyond mild euphoria or light drunkenness. It becomes clinically relevant when the level of intoxication interferes with daily functioning. During intoxication, several physical symptoms may also appear, such as slurred speech, slowed movement and impaired coordination, unsteady gait, nystagmus, reduced attention and memory, in severe cases, stupor, even coma. Now, let's turn to alcohol withdrawal. Alcohol withdrawal refers to the physical and psychological symptoms that occur when an individual who has been drinking heavily for a long period suddenly reduces or stops alcohol consumption. Symptoms usually begin with several hours to a few days after the last drink, and the presence of two or more symptoms meets the diagnostic threshold for withdrawal. Let's review some of the typical symptoms. Autonomic hyperactivity, such as a rapid heartbeat or excessive sweating. Hand tremor, which are among the most common signs. Insomnia, nausea, or vomiting. Hallucinations or illusions in some cases. Anxiety and psychomotor agitate, where the person feels restless and unable to stay still. In severe cases, seizures may occur. As we've discussed earlier, alcohol use disorder is not simply a matter of drinking too much. Over time, it becomes a progressive loss of control accompanied by increasing physical and psychological dependence. To better understand this process, let's look at Jelinek's model of the developmental stages of alcoholism. First, pre-alcohol phase. In the pre-alcohol phase, most individuals begin drinking for social reasons or to relieve stress. At this stage, drinking behavior is still under control and there are no obvious signs of dependence. However, the person gradually learns that alcohol provides relief or comfort, and drinking frequency begins to increase subtly over time. Second, prodromal phase. In the prodromal phase, both the amount and frequency of alcohol consumption rise. This is often when breakouts or memory lapse first appear, a sign that the brain's reward system is beginning to change. The individual may start hiding drinking habits or feeling guilt and concern about their use. Third, crucial phase. During the crucial phase, loss of control over drinking becomes apparent. The person may start drinking in the morning, eye-opener drinking, skip meals in favor of alcohol, and center daily routines around drinking. Social and occupational functioning deteriorated, and isolation increases as relationship with family and friends begin to break down. Fourth, chronic phase. Finally, in the chronic phase, complete loss of control occurs, physical health declines, nutritional status worsens, and the person often faces serious problems in work, family, and daily functioning. Despite these consequences, the individual continued to drink due to severe physical and psychological dependence. As we saw in Jelinek's model, alcoholism tends to progress gradually over time. However, in reality, not everyone follows the same developmental path toward addiction. The age of onset, underlying causes, and personality trait can differ significantly from person to person. To explain these differences, Cloninger proposed a two-type model of alcoholism, type 1 and type 2. Type 1, late onset alcoholism. Type 1 or late onset alcoholism typically develops in adulthood. In this type, both genetic vulnerability and environmental stressors contribute to the onset. Individuals with type 1 often experience more physical complications related to long-term drinking, but show fewer antisocial or interpersonal problems. In other words, they may maintain social functioning for a while gradually progressing toward dependence. This pattern is sometimes described as functional alcoholism. Type 2, early onset alcoholism. Type 2 or early onset alcoholism begins at a younger age and is more common among men. This type has a stronger genetic component and is closely associated with antisocial behavior, impulsivity, and interpersonal difficulties. Research shows that children of individuals with type 2 alcoholism are up to 12 times more likely to develop alcohol-related problems themselves. As we've seen, the onset and patterns of alcohol use disorder can vary from person to person. However, biological factors, particularly genetics and the brain reward system, play a central role in the development and maintenance of this disorder. Research shows that a strong genetic contribution to alcoholism. Children of individuals with alcohol dependence are about 4 times more likely to develop the disorder themselves. In addition, concordance rates for alcoholism are roughly twice as high in identical twins as in fraternal twins. This clearly suggests a heritable vulnerability to alcohol dependence. Alcohol activates the brain's pleasure and reward pathway. Primarily through the release of dopamine, a key neurotransmitter associated with pleasure and reinforcement. This activation produces feelings of relaxation and euphoria, and the brain begins to associate alcohol with relief and reward. Over time, this reinforcement loop encourages repeated and compulsive drinking behavior. With repeated and prolonged alcohol use, the brain's neural circuit undergo lasting change. Eventually, the individual becomes unable to maintain a normal emotional or physiological state with alcohol. At this stage, drinking is no longer voluntary. It transforms from a habit into a compulsive behavior driven to altered brain chemistry. Next, let's look at the psychological factors that contribute to alcohol-related disorder. From a psychoanalytic viewpoint, alcoholism has been explained through the concept of oral stage fixation. According to this theory, when a child's needs for care and nurturing during the early oral stage is either insufficiently met or overly gratified, the individual may later form dependent relationships with external objects such as alcohol. In times of stress or anxiety, alcohol becomes a substitute for emotional comfort and security. Early experiences such as parental loss, overprotection, or high family conflict can also interfere with the development of self-regulation and emotional stability, increasing vulnerability to addiction. Certain childhood traits are known risk factors for later alcohol dependence. For example, attention deficit, antisocial tendencies, and low assertiveness. The concept of an alcohol personality has also been discussed in clinical psychology. Such individuals tend to use alcohol as a means of emotional regulation or avoidance, relying on drinking as a form of self-medication when faced with stress or internal tension. Personality characteristics such as impulsivity, aggression, low frustration tolerance, and emotionally immaturity further heighten the risk. Cognitive expectation also play a significant role. When people believe that alcohol will reduce anxiety or improve mood, those expectations become self-reinforcing, sustain continued drinking behavior. Similarly, the tension reduction theory suggests that the relaxation and relief felt after drinking serve as powerful reinforcer, especially during adolescence or early adulthood. Over time, individuals learn an automatic association: when I'm stressed, I drink. Next, let's explore the socio-cultural factors that contribute to alcohol-related disorders. Every society holds different attitude toward drinking. For instance, in cultures where alcohol consumption is socially accepted or even encouraged, the prevalence of alcohol use disorders tend to be significantly higher. In contrast, Societies such as Islamic cultures, where drinking is restricted or prohibited, show much lower rates of alcohol addiction. In other words, how a culture perceives and value alcohol play a crucial role in shaping an individual's drinking patterns. The social meaning of drinking often determines whether alcohol is seen as recreation, relaxation, or risk. Social modeling has also a powerful impact. Family members, friends, co workers, and even the media can normalize or glamorize drinking behavior, portraying it as socially desirable or sophisticated. As a result, people, especially adolescents, tend to imitate and learn this behavior through observation. This modeling effect can strongly influence when and how individuals begin to drink. Lastly, stressful life conditions such as poverty, unemployment, or social instability can create feelings of helplessness and psychological distress. In such context, alcohol often become a means of coping or emotional escape. Ultimately, these social cultural factors provide the environmental backdrop and allow alcohol to function not merely as a recreation substance, but as a tool for coping with life difficulties. As we've seen, alcohol addiction is not merely an individual problem, it's a family illness that deeply affects every member of the household. Family dynamic play a crucial role in the maintenance, worsening, or recovering from alcoholism. The relationship is reciprocal. Family reactions can either aggravate the problem or serve as a catalyst for recovery. Unfortunately, in most cases, dysfunctional family patterns develop. Communication breaks down, roles within the family become distorted, and the cycle of drinking, conflict, more drinking repeated endlessly. In such families, marital conflict, domestic violence, and parent-child tension are common. As a result, family members often experience anxiety, guilt, low self-esteem, and depression. In other words, on one person's addiction destabilize the entire family's emotional health. Children growing up in alcoholic families are at high risk for later mental health difficulties. They may develop obsessive compulsive tendencies, social withdrawal, depression, anxiety, affection deficit, and even psychotic-like symptoms in severe cases. These problems often arise because the child learns unstable attachment patterns. Finally, the concept of codependence describes a situation where family members become pathologically entangled in the addict behavior. For example, a spouse or parent might cover up the addict mistakes, make excuses, or take over responsibilities, unintentionally enabling the addict to continue. In such cases, the family's attempt to help paradoxically sustains the disorder, highlighting the need for systemic family intervention, not just individual treatment. Up to this point, we've discussed how alcohol addiction affects the individual and the family. Now let's talk about how we can address the problem and support recovery. One of the greatest challenges in treating alcoholism is denial. Most individuals with alcohol problem either do not recognize the severity or believe they can control their drinking without help. As a result, many people only decide to seek treatment after hitting rock bottom. Because of this, effective intervention requires a multidisciplinary team approach. Psychiatrists manage the medical and pharmacological treatment, including withdrawal management and medication for craving control. Social workers and nurses provide patient care, education, and community reintegration support. Clinical psychologists deliver psychotherapeutic programs such as cognitive behavioral therapy and motivational enhancement therapy. From a traditional perspective, research suggests that controlled drinking is rarely effective. Instead, complete abstinence is considered the most realistic and beneficial goal. However, the relapse rate remains high, which continues to be a major challenge in long-term recovery. Recovery also depends heavily on environmental support. For individuals with unstable living conditions, such as the employed or homeless alcoholics, personal therapy alone is often insufficient. They require structured social assistance, including community shelters, rehabilitation centers, and local support programs operated by manipulate or public agencies. Ultimately, effective treatment for alcoholism must address both the psychological and the social dimensions of the disorder. Previously, we discussed how multiple professionals collaborate in the treatment of alcoholism. Now let's take a closer look at how psychotherapy is conducted as part of that process. While individual therapy can be effective, it is often costly and less accessible. Therefore, group therapy is more commonly used in clinical settings. In group therapy, confrontation techniques are applied to help clients recognize their own denial and minimization of problem. Patients are encouraged to face the consequences of their drinking and acknowledge the need for changing through peer feedback and mutual support. Additionally, children of alcoholics are considered co-victims of the disorder. They may participate in family sessions or attend separate group programs to address their emotional and relational difficulties. In the past, classical behavioral therapy, such as aversive conditioning, was used to create a conditioned aversion to alcohol. However, due to its limited efficacy and undesirable side effect, it is rarely used today. Currently, cognitive behavioral therapy is one of the most widely applied approaches. CBT integrates social learning theory and behavioral modeling to help clients identify irrational thoughts that trigger drinking behavior and to develop coping skills for high-risk situations. Research indicates that CBT is particularly effective for younger problem drinkers. Recently, mindfulness-based relapse prevention has gained increasing attention. This approach trains individuals to recognize early warning signs of craving, to respond with a non-judgmental attitude, and to increase self-efficacy in managing urges, thereby reducing the likelihood of relapse. Another powerful intervention is motivational interviewing. This focuses on helping clients discover their own intrinsic motivation for change rather than persuading or confronting. The therapist facilitates a process in which the client finds personal reasons to recover. In essence, motivational interviewing is not about telling someone to change, but about helping them want to change. In the previous section, we briefly mentioned motivational interviewing. Now, let's take a closer look at how this approach actually works in the process of change. According to Prochaska and DiClementis, stages of change model, individuals typically move through 5 stages when undergoing behavioral change. Pre-contemplation, the person is not yet considering change. Denial dominates this stage. Statements like, I don't have a problem or it's just stress are common. Contemplation, the person recognizes there is a problem but is not ready to take action. Typical thought might include, I should quit, but not right now. Preparation, the person begins to formulate concrete plans for change. They may start looking into treatment options or experimenting with cutting down on drinking. Action, the person takes active steps toward recovery, such as stopping alcohol use or joining a treatment program. Maintenance, the person works to sustain sobriety for 6 months or more and focuses on preventing relapse. This model emphasizes that change is gradual and cyclical. Rather than a one-time decision, based purely on willpower. Therefore, for therapists, identifying the client's current stage is crucial for choosing appropriate intervention. Finally, let's look at a representative example of social recovery, the 12-step program, best known through Alcoholics Anonymous AA. AA is worldwide fellowship with over 2 million members, built on the principle of peer support. Members share their experiences with one another, offering empathy instead of judgment, and through that process, they regain responsibility, humility, and self-awareness. The structure of AA is simple but powerful. It is grounded in the belief that you can't do that it alone, but together recovery is possible. Up to this point, we've explored alcohol addiction and its treatment process. Now, let's shift our focus on another form of addiction, one that does not involve substances but behavior. This is called behavior addiction, and among the most well-known examples is gambling disorder. Gambling disorder is not simply a bad habit or a financial issue. This is classified as a mental disorder characterized by persistent and recurrent maladaptive gambling behavior that leads to significant distress or impairment in person's life. According to DSM-5, a diagnosis of gambling disorder requires that 4 or more of the following 9 criteria to be met within a 12-month period. Interestingly, these criteria share core features with substance use disorder, including loss of control, tolerance, and withdrawal-like reactions. Need to gamble with increasing amount of money to achieve the desired excitement or arousal. Becoming restless or irritable when attempting to cut down or stop gambling, similar to withdrawal symptoms in substance addiction. Repeated unsuccessful effort to control, cut back, or stop gambling, preoccupations with gambling, such as persistent thoughts about past experiences or future betting plans. Gambles when feeling distressed, for example, to escape anxiety, guilt, or depression. Chasing losses, returning to gamble again in order to recover lost money. Lies to conceal the extent of gambling involvement from family or others. Jeopardizes or loses significant relationships, jobs, or educational opportunities because of gambling. Rely on others financially to relieve desperate situations caused by gambling losses. Thus, Gambling disorder is not merely a problem of money or self control, but a condition rooted in loss of behavior regulation and changes in the brain's reward circuitry. In the previous section, we reviewed the diagnostic criteria for gambling disorder. Now let's look at how those criteria actually manifest in behaviors and psychology. The core psychological feature of gambling disorder can be summarized as loss of control and denial of reality. Even when the consequences become severe, individuals are unable to stop. Instead, they rationalize, minimize, or conceal their behaviors. Here are some key psychological characteristics. First, continuing to gamble despite problems. Even when gambling causes significant personal, family, or occupational harm, the person continues to gamble. This is not simply a matter of weak willpower, but rather the result of the brain reward circuitry becoming overdependent on gambling stimuli. Chasing losses. When losses occur, the person tries to win back the money by betting larger amount or taking greater risk. This only deepens financial losses and perpetuates the vicious cycle. Gambling becomes a central focus of everyday life. Even when not gambling, the person remains preoccupied with thought, plans, or fantasies related to gamble. It often consumes leisure time, meals, and even family interactions. Common rationalization include this time I will win, or it's just a way to relieve stress. They downplay the seriousness of the problem and may lie to others to conceal their gambling behavior. They may misuse family funds, borrow from friends, or rely on others to escape financial crises caused by gambling losses. In severe cases, individuals may resort to fraud, theft, or embezzlement to fund gambling or pay back debt. As gambling dominates their life, interest in family, work, or personal obligations declines. Eventually, this leads to social isolation and emotional detachment. Ultimately, the psychological profile of gambling disorder can be summarized as combinations of cognitive distortion, distorted belief about luck and control, and emotional avoidance, using gambling to escape depressing emotions. Now let's turn to causes and risk factors of gambling disorder. Like other addictions, these origins are multifactorial, involving biological, psychological, and cognitive components. Research from family and twin studies suggests that gambling disorder has a genetic predisposition. In particular, the dopamine-based reward system in the brain tends to be overreact, making individuals more sensitive to the excitement of risk-taking and the anticipation of reward. In other words, such individuals experience a stronger rush or thrill when taking risks due to heightened neurobiological response in the brain reward circuitry. This exaggerated activation reinforces gambling behavior similar to how substances reinforce addictive use. From a psychoanalytic viewpoint, individuals with gambling disorder often exhibit compulsive or pathological personality trait. They may show a strong drive for stimulation or thrill, as well as an unconscious desire to defy authority or task limit. Sometimes gambling serves as an unconscious defense mechanisms to alleviate guilt, depression, or inner anxiety. Thus, gambling is not merely about seeking pleasure, it may also represent an attempt to soothe international conflict or restore damaged self-esteem. From a cognitive perspective, the core maintaining factor in gambling disorder is cognitive distortion. Examples include, this time I'm going to win. I can read the pattern. These reflect an illusion of control. The false belief that one can influence random outcomes. In addition, memory bias often plays a role. Wins are remembered vividly, while losses are quickly forgotten. This selective memory sustains the gambler's optimism and reinforces the cycle of play. Ultimately, these distorted thought patterns create the persistent conviction that next time will be different, which perpetuate the addictive behavior. From a learning theory perspective, gambling behavior can be explained as a result of reinforcement. First, positive reinforcement occurs when winning money produces excitement or pleasure, which encourages the behavior to continue. Second, negative reinforcement also plays a key role. People gamble to escape or avoid unpleasant emotions such as stress, anxiety, or depression. In addition, environmental cues, for example, casino light, sounds of slot machines, or certain places, can serve as conditioned stimuli that trigger gambling urges. In short, gambling represents a complex form of reinforced learning, where both the pursuit of reward and the avoidance of discomfort operate simultaneously. Certain personality traits can also act as causes or risk factors for gambling disorder. High impulsivity. Individuals will often act without considering negative consequences. They tend to make spontaneous betting decisions driven by emotion and prioritize immediate rewards over long-term outcomes. As a result, they struggle to stop even after repeated losses. People high in novelty seeking constantly look for new stimulation and excitement. For them, risk and uncertainty themselves become appealing. The tension and unpredictability of gambling function as a kind of pleasure. Some individuals are extremely competitive and easily frustrated when they lose. This strong desire to win leads to anger or irritability, and this mindset fuels thought like I have to win next time, which keeps the gambling cycle going. Finally, let's discuss social environmental factors. Gambling disorder is not only shaped by personal trait, but also by social context in which the person lives. A culture that normalizes or encourages gambling increases overall risk. When gambling is seen as a acceptable social activity, exposure became frequent and so does the likelihood of addiction. Lack of alternative leisure activities can also make gambling a convenient outlet for stress or boredom. People living under psychological distress, such as chronic anxiety, depression, unemployment, or financial strain, are more vulnerable, especially when combined with other risk behavior like alcohol use or smoking. Researchers show some gender related differences in gambling behavior. Men are more likely to start gambling during adolescence or early adulthood, whereas women tend to develop gambling problem later in life, often in middle age. These differences are influenced by social roles, stress factors, and across the gambling environment. Now, let's examine how gambling disorder affects the family system. Family members often experience shame, disappointment, betrayal, and a profound loss of trust. These emotions accumulate and destabilize family relationships. Suppose children and close relatives may suffer from anxiety, guilt, depression, and anger. It's not just a money issue. The emotional fabric of the entire family becomes disrupted. Debt and financial loss threaten the family's basic economic stability. As financial stress increases, daily functioning and quality of life deteriorate. Gambling often leads to marital conflict, parent-child tension, and in severe cases, family separation. As gambling continues, trust collapses and communication shut down, creating a vicious cycle of disconnection. Emotional stress can manifest as physical symptoms, for example, sleep disturbances, headaches, or gastrointestinal problems. Ultimately, gambling disorder is not an individual problem alone, but a family-wide crisis that affects emotional, financial, and physical well-being. Now let's move on to the final topic, support and intervention for gambling disorder. The core treatment approach is cognitive behavioral therapy. One of the key goals of CBT is cognitive correction. Identifying and restructuring distorted beliefs related to gambling. People with gambling disorder often hold irrational or distorted beliefs such as I was just unlucky this time, I can win it back next round. These reflect the illusion of control, the false sense of that chance outcomes can be influenced by skill or intention. They may also display selective recall, remembering wins vividly but forgotten losses, and engage in superstitious thinking, such as believing that a dream, a ritual, or a lucky member will lead to success. Recognizing and correcting this cognitive distortion is the first step in CBT. The next focus is training a problem solving and cognitive strategies. Helping clients manage stress, regulate emotions, and avoid situations that increase the risk of relapse. Another important component is social skill training, which aims to rebuild damaged interpersonal relationships and strengthen social functioning. Since gambling often isolates individuals from family and friends, restoring this connection is a crucial part of recovery. Finally, relapse prevention is essential because addiction is chronic and relapse prone. Clients must learn to identify triggers, cues, or situations that spark gambling urges and develop healthier ways to respond to them. Building self-awareness and self-regulation is central to long-term success. Social support also plays a major role in recovery. A well-known example is Gambling Anonymous, a self-help program modeled after Alcoholics Anonymous. In GA, members meet regularly to share experiences, provide emotional support, and encourage one another in maintaining abstinence. What makes this approach powerful is that it is not therapist-centered but rather based on mutual support among peers. These peer groups not only help individuals stop gambling, but also assist them in rebuilding a social network that supports a life free from gambling. Research shows that combining professional treatment like CBT with peer-based programs like GA lead to lower relapse rates and a higher likelihood of sustained recovery over time. Today, we explore substance-related and addictive disorders. We first examined alcohol use disorder, focusing on nature of substance dependence and its major intervention strategies. Then, through gambling disorder, we'll look at behavioral addiction, understanding its unique psychological mechanisms and treatment approaches. Both disorders share two central features: loss of control and alternations in the brain reward system. However, clinical approaches may differ depending on whether the addiction involves a physical substance or behavior, and how society perceives each form of addiction. As you review this topic, I encourage you to reflect on these commonalities and distinctions, and on the core principles of effective intervention and recovery. That concludes today's lecture. Thank you for your attention, and I hope this session deepen your understanding of human behavior, addiction, and the path toward recovery.